that the CNI monitor could be useful in trying to identify whether or not a drug is effective much earlier than the typical timeline for clinical development. So we often have patients getting a new investigational drug or a combination of drugs, and they're treated for a number of cycles before we get the first readout from a scan. And some of the issues, especially when we're talking about immunotherapy, are we have some additional compounding factors that make interpretation difficult. One of them is pseudotumor progression, where the cancer initially enlarges because of factors such as immune response, and the patient may look like they're progressing where in fact they're feeling usually better than they were when they started on treatment. And the other issue is hyperprogression, where the cancer is actually in fact doubling or tripling faster than they were prior to getting that treatment. The CNI monitor can help differentiate these two categories, as well as give an earlier readout of who might be benefiting from this treatment well before a scan is available. One of the challenges with immunotherapy, especially combination therapy, is that there are very few markers that we can use that are useful in identifying those who may benefit. So what happens in general, our patients are just treated as a whole with immunotherapy compounds. There are some tests like immunohistochemical that might identify a subset of patients that might benefit, but what happens in practice is the majority of patients at some point in their treatment spectrum are going to get access to immunotherapy, and we need to have a test that can help us identify sooner rather than later whether or not these patients are truly benefiting from this treatment, and also know that if there is a chance that this cancer is progressing faster than you would expect, to take them off that treatment, or if they're having the potential benefit from pseudotumor progression, which is still pretty rare, but knowing that hang in there, the scan looks a little bit worse, patient's feeling better, and have the additional confidence that the CNI monitor might be able to tell you that this patient is likely going to have an improved response later down the road with the next set of scans. The primary objective was to determine if CNI, or circulating free tumor DNA, would identify patients that are responding or progressing on therapy sooner than traditional imaging techniques such as RECIST or immune response RECIST criteria. The secondary objectives were to see if this treatment could differentiate responders from non-responders, and also if there was a correlation between tumor burden and the amount of circulating free tumor DNA in the sample. Additionally, there was another secondary objective where we're looking to see if tumor markers, when present in the cancer, would perform as well or better or worse than the CNI test.